Today, we are breaking down human immunodeficiency virus HIV, a classic high-yield board topic and a crucial clinical subject. Let's start with the structure of the virus. HIV is an enveloped positive sense single-stranded RNA virus belonging to the Retroviral family. Let's examine it from the inside out. Deep inside the virion, HIV carries two copies of its single-stranded RNA genome along with three essential viral enzymes: reverse transcriptase, integrase, and protease. Moving outward, this genome is housed within a conical capsid made of the P24 protein, which serves as the key antigen targeted in early diagnostic testing. Directly surrounding this capsid is the P17 matrix protein, which provides structural integrity to the virus. Finally, the outermost layer consists of a lipid bilayer derived from the host cell membrane. Embedded within this final barrier are viral spikes composed of glycoprotein complexes, where each spike forms a trimer of the GB120 outer docking subunit and the GB41 transmembrane fusion subunit, both of which are coded by the ENV gene. HIV transmission between hosts requires direct contact with specific bodily fluids containing a high viral load, like blood, semen, vaginal secretions, and breast milk. First, sexual transmission represents the most common global route, where microtears in mucous membranes allow the virus to access CD4 positive T cells. Second, parenteral transmission occurs via intravenous drug use, where two or more people share the same syringe or needle, or through accidental needle stick injuries in healthcare settings, such as during needle recapping, disposal, sudden patient movement, or surgery. And historically, it also included blood transfusions performed before strict screening protocols. Third, vertical transmission from an infected mother to her child can happen in utero across the placenta, intrapartum during delivery via exposure to blood and vaginal fluids, or postpartum through breastfeeding. Conversely, HIV is not transmitted by saliva, sweat, tears, or non-intimate contact because the viral concentration in these fluids is completely insufficient. The replication of HIV follows a highly coordinated 7-step sequence within the host cell. First, during binding, the viral GB120 attaches to the host's CD4 receptor, primarily on T helper cells, macrophages, dendritic cells, including a conformational change that enables binding to either the CCR5 or CXCR4 co-receptor. Subsequently, fusion occurs as GB41 penetrates the host cell membrane, allowing the viral envelope to fuse and release the viral capsid into the cytoplasm. Next, reverse transcription takes place, where the viral enzyme reverse transcriptase converts single-stranded viral RNA into double-stranded complementary DNA. Following this, during integration, the viral DNA enters the host nucleus, where the enzyme integrase inserts the viral DNA directly into the host genome. Thereafter, replication proceeds when host cell activation triggers the transcription of viral DNA into viral messenger RNA, which is then translated into long, non-functional polyprotein chains. Moving forward, assembly begins as a new viral RNA, and these polyprotein chains migrate to the cell surface to form an immature non-infectious virion. Finally, during budding and maturation, the immature virion buds off from the host cell, taking a piece of the host membrane. Simultaneously, once outside, the viral enzyme protease cleaves the polyprotein chains into functional proteins, completing the architecture remodeling that transforms the virion into its mature infectious form. HIV targets and destroys CD4 positive T cells via several primary mechanisms that ultimately cause the immune system to collapse. First, direct viral lysis occurs when the sheer volume of viral budding ruptures the host cell's plasma membrane, leading directly to cell death. In addition, pyroptosis and apoptosis function as the dominant mechanisms of cell destruction, causing infected or uninfected bystander cells to undergo programmed cell death. Finally, the host immune response itself actively drives the CD4 positive decline through T cell mediated killing, a process wherein CD8 positive cytotoxic T cells recognize viral peptides presented by MHC1 on infected CD4 positive cells and destroy them. Left untreated, HIV progresses through three distinct clinical phases over a timeline of years. Phase 1 is acute retroviral syndrome. This initial stage occurs roughly 2 to 4 weeks after HIV infection, during which patients experience a rapid surge in viral replication that triggers a severe mononucleosis-like illness. Consequently, the host immune system initiates an aggressive response, leading to classic systemic symptoms such as high fever, generalized lymphadenopathy, maculopapular rash, sore throat, and severe myalgia. Meanwhile, laboratory findings typically reveal a sharp transient drop in CD4 positive T cell counts alongside a massive spike in plasma HIV RNA levels. Ultimately, as cytotoxic T cells begin to contain the viremia, these acute symptoms resolve spontaneously within a few weeks, guiding the patient into the prolonged asymptomatic chronic phase of the infection. Phase 2 is a clinical latency or chronic HIV infection. Following the acute phase, the infection transitions into clinical latency, a period during which the virus replicates actively within the lymphoid tissues despite being largely asymptomatic. Throughout this prolonged stage, the host immune system manages to maintain a fragile equilibrium with the pathogen. Consequently, while plasma viral loads remain relatively stable, there is a slow destruction of CD4 positive T cells over time. Ultimately, as the immune system is gradually exhausted, this latent period terminates, inevitably progressing to AIDS if left untreated. Phase 3 is acquired immunodeficiency syndrome or AIDS. This final and most severe stage of HIV infection occurs when the immune system becomes profoundly damaged, specifically defined by a drop in CD4 positive T cells below 200 cells per microliter, or the presentation of specific AIDS-defining illnesses. Due to this severe depletion of the helper T cells, the host loses cell-mediated immunity. Consequently, patients become highly susceptible to life-threatening opportunistic infections such as pneumocystis pneumonia and rare malignancies like Kaposi sarcoma. Furthermore, constitutional symptoms like profound weight loss, chronic diarrhea, and prolonged fevers often emerge during this phase. Ultimately, without aggressive antiretroviral therapy to restore immune function, this profound state of immunodeficiency compromises vital organ systems and leading to death. By combining multiple classes of drugs, antiretroviral therapy effectively suppresses viral replication to undetectable levels. As a direct result, this intervention stops disease progression, successfully extending the clinical latency phase from 10 years to many decades, effectively providing a normal human lifespan. Simultaneously, by preventing the destruction of CD4 positive cells, antiretroviral therapy improves the patient's quality of life, ensuring they don't suffer from opportunistic infections, wasting, or chronic illness. Furthermore, this therapeutic success achieves the clinical standard of U equals U, or undetectable equals untransmittable. Specifically, when a patient's viral load remains undetectable for at least 6 months, their risk of sexually transmitting the virus drops to zero. What exactly is an AIDS-defining condition? These are specific opportunistic infections, malignancies, or conditions that rarely cause severe illness in immunocompetent individuals, but thrive when CD4 positive immunity is lost. Finding any of these in an HIV positive patient confirms the diagnosis of AIDS. AIDS defining conditions are fungal infections include pneumocystis jirovecii pneumonia, characterized by classic ground glass opacity on chest X-ray, as well as esophageal candidiasis, cryptococcal meningitis, and disseminated histoplasmosis. In addition to these, severe viral reactivations involve cytomegalovirus retinitis, which can cause blindness, and progressive multifocal leukoencephalopathy driven by the JC virus. Meanwhile, classic bacterial complications typically present as disseminated Mycobacterium avium complex or extrapulmonary tuberculosis. Furthermore, important protozoal diseases include Toxoplasma gondii encephalitis, which presents with ring-enhancing brain lesions alongside chronic cryptosporidiosis causing severe watery diarrhea. Finally, the clinical picture concludes with specific HIV-associated malignancies, notably Kaposi sarcoma, which is caused by HHV8 virus and presenting as purple skin nodules, primary central nervous system lymphoma, and invasive cervical cancer. The modern diagnostic algorithm for adults relies on a precise two-step process performed on blood samples. First, a screening test is conducted using a fourth-generation combination assay, which simultaneously detects HIV-1 and HIV-2 antibodies and the P24 viral antigen. Because it identifies the P24 antigen, this assay can spot an infection weeks before the body even creates antibodies, effectively narrowing the window period. Subsequently, if this initial screening returns a positive result, a confirmatory HIV-1 and HIV-2 antibody differentiation immunoassay is performed to establish whether the patient has HIV-1 or HIV-2. However, if the screening is positive but this confirmatory antibody test is negative or indeterminate, clinicians must order an HIV nucleic acid test or PCR. Specifically, this step looks directly for viral RNA to catch an ultra-early acute infection. The gold standard regimen for a newly diagnosed patient is triple therapy, which combines the three drugs from at least two different classes to prevent the virus from developing drug resistance through mutations. Structurally, this standard algorithm combines a dual nucleotide reverse transcriptase inhibitor's backbone with the highly potent anchor drug, ideally an integrase transfer inhibitor. Let's look at the primary drug families and their mechanisms. Antiretroviral therapy relies on five main drug classes targeting distinct stages of the viral life cycle. First, nucleoside or nucleotide reverse transcriptase inhibitors function by acting as faulty or fake building blocks to cause premature viral DNA chain termination. Second, non-nucleoside reverse transcriptase inhibitors operate by binding directly to the reverse transcriptase to allosterically inhibit its activity. Third, integrase transfer inhibitors achieve these effects by blocking the integrase enzyme, preventing viral DNA integration into the host genome. Fourth, protease inhibitors target the virus by inhibiting the protease enzyme to prevent viral polyprotein cleavage, leaving newly budded viruses immature and non-infectious. Finally, entry or fusion inhibitors work by physically preventing the virus from docking or fusing with the host cell membrane. Although HIV-infected neonates are usually asymptomatic at birth, their immature immune systems can cause rapid disease progression within the first few months, presenting with signs like hepatosplenomegaly, persistent oral thrush, interstitial pneumonia, and failure to thrive. To diagnose them, standard antibody screening tests cannot be used due to the transplacental maternal antibodies. Instead, clinicians must rely on direct HIV DNA or RNA PCR assay at birth 1 to 2 months and 4 to 6 months.